Om Amriteshwari Namaha. A warm good evening to each and every one of you. I am Abhirami Jaykumar, the host for the day, and my co-host is Miss Anjali EA. We are gathered here today at the Kochi campus of the AMRITA alumni for an enlightening talk on a vital topic on women's health by our alumna, Dr.ANU JOSEPH, on how small is small, how to diagnose and tackle growth restrictions in fetus. Today, we are gathered here as advocates for a cause that affects every woman and in turn the whole society health. Let me move on to the proceeding by invoking the blessings of our beloved Amma with lamp lighting. Our medical director, Dr. Prem Nair sir, a humble person who stays calm in every situation, making the impossible possible. Under his visionary leadership, AMRITA Hospitals has evolved into India's largest private healthcare institution, setting a benchmark for accessible and top quality healthcare services. I welcome Dr. Prem Nair sir, Provost and Group Medical Director, AMRITA Hospitals, India.
Thank you very much. Om Amriteshwari Namaha. Distinguished chief guest, faculty members, and my dear students. A very good evening to all of you. I extend a very warm welcome to all those gathered here today. I would also like to express my gratitude to our chief guest, Dr. ANU JOSEPH, MBBS 2002 batch alumna. Today, as we come together to share experiences, insights, and wisdom, let us reflect on the transformative power of education. As our beloved Amma says, our educational system needs to give equal importance to the intellect and the heart. It reflects a commitment to nurturing well-rounded individuals who are not only knowledgeable, but empathetic, resilient, and socially responsible. As we move forward with our event today, I encourage everyone to actively engage with Dr. ANU and make this session a valuable learning experience. Let us take this opportunity to ask questions, share our thoughts, and learn from her experience and expertise. I would like to appreciate all the efforts made by the AMRITA Alumni Association to make this online program possible. Their dedication and hard work have brought us together, even in a virtual setting, to celebrate the spirit of learning and community. Wish you all the very best. Om Amriteshwari Namaha.
Thank you, Dr. Prem Nair sir, for those words. An emergency physician and currently the principal of AMRITA School of Medicine, he started the first emergency medicine specialty in Kerala. I welcome Dr. Girish Kumar sir, principal, AMRITA School of Medicine, AIMS, Kochi. Now, I would like to welcome our esteemed panelists for today. I welcome Dr. Radhamani K. Ma'am, Emeritus Professor, Department of OBG, AIMS, Kochi. She is the pillar and strength of Gynaecology department. Her dedication to excellence has earned numerous awards and recognition within the medical community, reflecting her unwavering commitment to women's health and well-being. Dr. Fetal is a distinguished professor and head of the department in reproductive medicine and surgery, specializing in infertility, IVF, IUI, PCOS, male infertility, and endometriosis. Dr. Fessy is dedicated to providing comprehensive reproductive care. I welcome Dr. Fessy Louisa, Professor and Head, AMRITA Fertility Center. Dr. Shobha S. Nair, Professor and Head of the Department, specializing in robotic and laparoscopic gynecological surgeries and cutting-edge research. She is MS, MRCOG, and extensive training in laparoscopy and robotic surgery. She brings over 20 years of expertise to her practice. I welcome Dr. Shobha S. Nair, ma'am. I welcome Dr. Vivek Krishnan sir, in charge, Fetal Medicine Unit, AIMS, Kochi. He is known for his extensive work in fetal medicine. I welcome you, sir, to this session. I welcome the soul behind this session, Dr. P.G. Nair, ma'am, Emeritus Professor, Pharmacology, Coordinator of Nodal Office for Statutory Inspections, and Chief Coordinator for Campus Alumni, AIMS, Kochi, without whom this session would not have been possible. Next, I would like to welcome the speaker, Dr. ANU JOSEPH, ma'am, MBBS 2002 batch alumna, DNB, Maternal Fetal Medicine, Senior Consultant OBG and Fetal Medicine, Kauvery Hospital, Bengaluru. Dr. ANU JOSEPH is one of the brightest stars of 2002 MBBS batch. She is compassionate and patient-friendly doctor, equipped with good knowledge in the field of gynecology, high-risk pregnancy, and fetal medicine. I welcome you, ma'am, to this session. I would also like to welcome Anjali EA, Executive, Alumni and Nodal Office, AIMS Kochi. She is my co-host of this session. Last but not the least, I welcome all the faculty members, staff members, and the students to this session. Now, I call upon Dr. ANU JOSEPH, ma'am, to share her insights on this topic. Over to you, ma'am.
Thank you so much for that kind introduction. With the chair's permission, I would like to start sharing my... So today's topic given to me is about growth restrictions. How small is a topic that we have chosen. I hope the screen is seen to everybody. The screen is visible.
Yes.
So this is 2002 batch for all of you. I come from the first of people who passed MBBS from AMRITA Cochin campus, and one among them is me. And after years of being out of campus, coming back there and giving a talk is nothing less than a miracle for me, a happiness for me, something that I always wanted to do. So let's start the talk. I am roll number 15 of first batch of MBBS. I would like myself to be introduced the same way. Going forward with the talk, we need to have a basic understanding of what fetal growth restriction is. Fetal growth restriction implies that there is a pathological restriction of genetic growth potential. So that is something that any day we talk about fetal growth restriction, we need to understand. It's just not being a small baby. It needs to be understood at a level that this baby had a potential to grow, but for some reason it is not growing. And that is where we call it as growth restricted baby. And that is the prime pivot at which the entire talk is going to be. Now, in addition to being growth restricted, these babies may show, or these fetuses may show evidences of fetal compromise, like an abnormal Doppler or a reduced Leica or any other complications that the fetus may have. And as such, this is a very complicated process. The fetal restriction process itself, diagnosing it, and as well as managing it becomes a challenge because the entire issue is not just very straightforward. So the idea of this talk is not to teach you in detail what is growth restriction, but it is to understand that, okay, a problem like this does exist. It is a common problem. It is something that we may come across whichever field we may be opting to choose to be in. And it is important that we educate our women and ourselves to understand there is a problem which can be prevented, which can be detected early, which can be screened for, and to a great extent managed if understood early enough. To define, since it's a complicated problem, it also has complicated definitions. The definitions do not really do too much of a justice to the problem, because even though we define these, there may be growth restricted fetuses which do not really fit into these definitions. For the ease of work, definitions have been sorted into as any fetus which is having an expected fetal weight less than 3rd centile, or an abdominal circumference less than 3rd centile, or any of these less than 10 centile with combination of other Doppler changes, we can call them as growth restricted babies. Now, there is also a difference between whether it is an early onset or a late onset growth restriction, usually depending on the time or the gestational age at which we have found out they are growth restricted. These are something that has its own gray zones. When we come into the clinical aspect of it, it may not be so 0 and 1. It may not be very binary, but this is something that is going to give us an idea. Okay, let's try and put them into these boxes and try and treat and manage these pregnancies. Now, when we come to saying that, okay, this definition is not going to be a great definition or a complete definition or 100% fits all fetal growth restriction, the problem is there is something called as a suboptimal fetal growth also, which also may be indicative of a fetal growth restriction. It may be a onset of fetal growth restrictions. For example, a baby who was growing now at 50th centile, probably in your anomaly scan, your 5th month scan, now comes at 28 or 30 or 32 weeks, the next scan that you did, it has gone into a 20th centile. It did not go into the 10th centile as per your definition, but it did go into the 20th centile, and something rings a bell and says, okay, why did this happen? Now, what do we do with such fetuses? The definition doesn't tell us. The definition tells us that it is a normal baby. Still, it is not a growth restricted fetus. Also, growth above 10 centile, if they start showing Doppler changes, what do we do about them? And also the fact that growth is always a progressive dimension. It cannot be assessed at one scan. So we are talking about one scan, which tells us, okay, is this baby growth restricted or not? Today, it may not be. After 1 month, it may be. So a few of them was taken into consensus in something called as a Delphi consensus, which said, okay, few AC and EFWs crossing centiles greater than 2 quartiles can also be considered as growth restriction. So this is an ongoing process. Defining them, defining the issue is actually an ongoing process still. Associations of a growth restriction can be maternal, fetal, or placental. The maternal associations are something that any one of us may come across. You're a rheumatologist, you're a cardiologist, you're a physician, you're a gynecologist, you're a fetal medicine expert, you are a neurologist. Any of these associated issues, if the mother has, there is also a possibility, if it's a chronic issue, it may end up in a pregnancy with a fetal growth restriction associated. The drugs that the mother may be prescribed, the issues of anemia that some drugs may cause, the issues with placentation that some drugs may cause. So The maternal factors of fetal growth restrictions would be important for any of our super specialty and subspecialty. Fetal causes, yes, if the baby has some sort of congenital malformations, congenital anomalies, genetic issues that may be causing a fetal growth restriction, and usually much earlier than what we expected to happen. Placental causes are the commoner causes where placenta is deficient due to X, Y, or Z reason, and there is suboptimal placentation, suboptimal nutrition for the baby, and hence the baby doesn't grow so well. The small fetuses also can be in those association be a little classified into normal, that is constitutionally small. They're not fetal growth restricted baby, they're just constitutionally small, which means if the mother is small, it is one of the maternal factors. Mother is small built, father is small built, baby can also look small built. There can be non-placenta mediated growth restriction, which is what we told about. Placenta may or may not be, may be mostly normal, but due to other reasons, baby is small. And placenta mediated, placental growth restriction, mediated growth restrictions. The classification of early onset fetal growth restriction and late onset fetal growth restriction is something that we will read about, listen to when we start reading about fetal growth restriction. And when we read, it always looks as if there is a good equilibrium between the two. There is something that we can say, okay, this is early growth restriction and that is late onset fetal growth restriction. But when it comes to actual practice, there is a combination of both in any fetal restrictions that we see. Usually the problem with early onset fetal growth restriction, which are the smallest component of fetal growth restriction, the problem is with management, because they are picked up very early because we are doing early anomaly scans, we will see them. But managing from around 5th to 6th month and taking them to 9 months of pregnancy and delivering them at term is going to be a big time management problem for us. And usually the placental disease is quite severe and we may not end up taking the pregnancy to term, and hypoxia and babies' cardiovascular adaptation issues, and most likely delivering an immature, a preterm, low birth weight baby is quite high, and hence the mortality and morbidity is quite significant in this group. But thankfully, the number of early onset fetal growth restriction in its pure form are way less. And so the numbers of mortality and morbidity that we see is way lesser than what we would see with late onset fetal growth restriction. Late onset fetal growth restriction, on the other hand, the problem is always with diagnosis, because a later on scan may not be a go-to scan at all places. In place like AMRITA, or in a place where I work at Kauvery, which is a multi-speciality hospital, we would be doing multiple scans for patients for multiple reasons. But in a rural setting, after an anomaly scan, patient may directly come for a delivery. And in between all this, they may not have had a proper antenatal checkup. They may not have had symphysiofundal height checkups. They may not have had any scans. They may not even have checked their glucose for all we know. In such conditions, or in conditions where everything is available, but scans were done a little too late or a little too early and we missed on a fetal growth restriction, that becomes a problem of late onset fetal growth restriction. We may not diagnose them on time. The placental disease is mild, so the changes that we see comes very slowly, and the hypoxia component of the baby, if managed well, is generally way less. And most of the time, if detected on time, we can deliver a baby at term with usually a good maturity, because they are term, and also they would be way better in terms of not requiring an NICU stay, probably directly being able to shift it to the mother side. So the outcomes are generally better. But when we don't diagnose them, the outcomes are way poorer, because we think everything is fine. We wait towards full term, and the long-term outcomes in such babies and chances of stillbirths are way higher. Now, taking this as our background knowledge, we need to understand why is this important, that we should know there is something called as fetal growth restriction exists. In what I told just before in the previous slide, we would have understood early detection can, to a great extent, help us manage the outcome. So unless we know there is a problem, we are not going to try and detect it early. And unless we detect it early, we are not going to manage the problem and hence have a favorable outcome. Also, unless we know there can be a problem coming in the background, we are not going to ask to modify risk factors. If we know, okay, there is a fetal growth restriction that may happen with this risk factor, we will ask the mother to modify the risk factor. Also, there will be some time that we will have to correct the disease process. For example, using of aspirin in women who are at risk for fetal growth restriction is a well-studied methodology of trying to prevent growth restriction. Surveillance methodologies can be charted up. We know, okay, this baby is going to be growth restriction. It is at risk for growth restriction. We can tell the mother, we can chart in our department, we can tell our unit that, okay, this mother is going to need much better surveillance than our routine antenatal care women. Also, we will be able to tell the parents, the prospective parents, these are the delivery considerations we are going to look for. Your baby may need an NICU. You may have to deliver a little preterm. You may have to think about, finances about using an NICU stay. And with all these things, we will be able to do a proper and justifiable counseling to the parents, both in the short term, which is now what is happening, in the long term, what are we planning to do for this pregnancy? And of course, if we have a borderline or a bad outcome in this pregnancy, how to manage the same problem if it happens in future pregnancies. Then comes the question, how do we detect? So the age-old method of antenatal care and finding out growth restriction was two, symphysiofundal height and maternal weight gain. Now, this has changed a little. I'm not telling that the clinical evaluation is not important, but from a clinical evaluation based antenatal care, we are now moving a little towards ultrasound biometry and Doppler evaluation for detection of fetal growth restriction. Sensitivity, specificity, both changes when we change from clinical evaluation to using ultrasound for detecting, diagnosing fetal growth restriction exists. So at that point of time, reducing mortality and morbidity associated with fetal growth restriction becomes our much important problem statement. And for this, what are our requirements? We have to make sure that we know which are the pregnancies at risk, or which are the mothers at risk, or rather which are the women at risk. We need to understand and diagnose fetal growth restriction. We need to demarcate the growth restricted baby from a small for gestational age baby, which is a normal baby with a normal growth trend. And we have to also avoid unnecessary preterm and early term deliveries due to wrong diagnosis. So every time this happens, whenever there is a program where we start talking about detecting more, this is an issue, let's make sure that we detect this more, there is always an increase in also normal children being diagnosed as abnormal children. Now that part also we will have to educate to make sure that, no, this let us not do. So let's correctly diagnose, let's correctly demarcate, and make sure that all babies are delivered at the time that they need to be delivered. In addition to all this, when we are talking about the fetus, what changes or what makes things a little more complicated is the maternal factors that come in. In a great number of pregnancies which are complicated by fetal growth restriction, there is also going to be a maternal component to it. Many a times, preeclampsia, pregnancy-induced hypertension, or much more complicated ways of preeclampsia, where a straightforward protocol may not help us. or the mother may have some other issues like an uncontrolled diabetes, where all our plans of managing a fetal growth restriction in a very straightforward way gets complicated. So that is also important, not to look just at the maternal, just at the fetal side, but also to give due consideration for the maternal factors. So now that we know this problem statement, we need to identify who are the pregnancies at risk. So there are, if you go through literature, there are n number of maternal issues that has been documented as most likely causing fetal growth restriction if there is a history that can tell us. So there might be a baby previously born or a stillbirth or severe preeclampsia, which will tell us this mother may have again a fetal growth restriction. There are certain blood tests and screening methodologies which will tell us, okay, this mother may be at risk. There are ultrasound abnormalities like a single umbilical artery or a congenital abnormalities, which will tell us, okay, going forward, we will have to be careful about it. Certain infections that come up to the mother, which may spread through the placenta to the baby, can cause fetal growth restriction. So when all these factors exist, the question always is, then can we put all these factors and say yes or no and put it into a software and create a software where we can have a risk identification? Now, the trouble with it is there are lots of studies which has done it. Few studies which looked at preeclampsia and predicting preeclampsia also tells us a little about predicting fetal growth restriction. But those studies are way concentrated on the placental issues of fetal growth restriction. And like I said, there will be a maternal component to it. For instance, how to put in a maternal neurological or otherwise troubled maternal history into the software is a question that we don't know. How much do we put a point to that? So how do we predict all this? Then racial changes. People of Indian origin may have a different kind of a growth velocity or different kind of risk attributable to a certain problem than a person of some other racial origin. So such things make having a software and predicting it a little difficult for us. Prevention, there are possibly two. Seniors can always guide me if I've missed on anything. Basically, it revolves around two things: lifestyle modification, wherein we make sure that the pregnancy itself is attained at a much better lifestyle place, wherein the weight is well controlled, diet is good, adequate water intake is there, exercise is there, and the patient is well fit enough for a pregnancy. And antenatally at-risk women can be given aspirin. And detection. Now, this is $1 million question. What is the optimum surveillance pathway for a woman according to their risk for FGR, and how to diagnose fetal growth disorders? I don't think any one of us have a right answer to it, because the word optimum surveillance make a twist there. There is no optimum surveillance. We'll have to take each patient as they come. We have to tailor make according to the background issues that they have and the present ultrasound features that they have, and make sure that they go home with a healthy baby. So there is nothing called as an optimum surveillance pathway. We will have to tailor make it. Coming back to the clinical examination, abdominal palpation and symphysiofundal height are the two age-old methods of seeing if growth restriction is there. Like I said, clinical examination is very relevant, especially after 24 weeks. And it can be one of those indicators for us to even tell, okay, please, it looks a little small, little big, go and have an ultrasound done. That might be the first reason for somebody to tell, go get an ultrasound done to diagnose. But can it be used for diagnosis of fetal growth restriction? In today's world, may not be the best choice. Ultrasound. The question when it comes to ultrasound, detection and diagnosis of fetal growth restriction on ultrasound, nobody has a question. Yes, that's the best way to do that. But the question is, whether do we do a routine ultrasound to all women, or do we strategize them, or do we categorize them into low risk, medium risk, or high risk, or low risk and high risk, and then give ultrasound only to those women who are at high risk, and for the rest of the women we only give routine antenatal care without ultrasound examination? Now there are two problems to it. Like I said, clinical examination may not be the best of things that we do. Probably Dr. Radhamani might be the best person to do it, but when it comes to my hand, I may have an observer dependent change. I may say 34-week abdomen looks like 32 weeks. I may think that 32 weeks growth restriction, okay, this baby is growth restricted, or I may overlook it. Ultrasound doesn't do that. But if we were giving it to only at-risk women, then it is on the observer, it's on the doctor to decide, okay, is this women at risk? So some women who actually have a growth restricted baby may miss on the opportunity to get an ultrasound. Second problem, which is a problem that we see commonly nowadays, is associated fetal anomalies which are being picked up in the third trimester. There is something called as evolving anomalies in the fetus, which we may miss in the second trimester anomaly scan, and we may pick it up only in the third trimester. So giving ultrasound as an option to only high-risk women, we may miss on those evolving anomalies as well. So according to me, ultrasound should be a routine. Now, if we decide that, okay, fair enough, let ultrasound be routine, then we will have to also ask the question, or rather, if not, then categorizing them for low risk, moderate risk, and high risk, will it work? If we consider, okay, let's give it routinely, then the question comes, when do we do it? Do we do it starting 24 weeks? Do we do it at 28, 32, 36? A general consensus is as long as the 20 weeks anomaly scan was fine, it is okay to at least start at 32 weeks. But at 28 and 24 weeks, we do have a antenatal checkup where at least the symphysiofundal height was measured. Uterine artery Dopplers are an adjunct to screening for fetal growth restriction and also to understand regarding the future surveillance pathways. So in the first trimester, when we do the NT scan, I hope everybody is well aware of what is an NT scan. It is the scan done primarily to understand about genetic issues, most likely Down syndrome. But here we have an opportunity to do ultrasound examination of the uterine artery, which shows a particular waveform with which we can do some amount of risk prediction for placental health. And a placenta which doesn't work well, we can extrapolate that data into understanding this baby may go in for fetal growth restriction. And if you put that into a very commonly available software, it would tell us high risk for preeclampsia, high risk for fetal growth restriction. And such women, we can put them on prophylactic aspirin, and we can ask them for proper surveillance. And with that proper surveillance, we may be able to have an early detection in them. Whereas when it comes to the second and third trimester, uterine artery Doppler doesn't have a predictive capacity. So starting aspirin way late in second or third trimester may not give us a good outcome in preventing fetal growth restriction, but it can tell us, okay, this baby needs to be having a better surveillance pathway than a non-at-risk woman.
Meeting.
Now, once we see that we have a fetal growth restriction, then we need to understand, okay, how are we going to manage it? Now, mild fetal growth restriction, which has come up way later in gestation, are kind of decent that way. We get time, we understand there is always a cascade. There will be certain amount of Doppler shift. There will be changes in various Doppler that we study. There will be a uterine artery Doppler which will go up. There will be middle cerebral artery which will start showing changes. There will be umbilical artery changes that will happen. So there is something called as a cerebroplacental ratio which will start going down. And one after the other, one Dopplers will start changing, and we will have this time to tackle them and probably still take them towards term and deliver. So there we are a little more happy. But if we fail in that surveillance, we are still going to have hypoxia, acidosis, and probably stillbirth or a long-term bad outcome. But there we are a little more happier in managing them because we know how to manage. Whereas when it comes to early severe fetal growth restriction, the placental disease starts way early. The baby's growth restriction starts way early. We may not get time to take them to term, and we may have way late changes, which may make sure that the outcomes are bad if we don't keep them for better surveillance management. There is a long algorithm given for managing fetuses with growth restriction. Not going into the details of it, but there is something that we can work with. Does it always happen to go through this pathway? May not be, but this is something to start with. People have worked way too much to bring about something like this. It works in good number of women with fetal growth restriction. But like I said in the beginning of my talk, it is always going to have a gray zone where you will have to tailor make it for your pregnant patient. This is again something which is given as a part of how to manage a simplified version. We can stage fetal growth restriction into stage 1, 2, 3, and 4. And as the numbers go up, it becomes a little more serious. So the monitoring becomes a little more careful, and we do cesarean. We do cesarean or delivery based on how early complications happen in them. This is kind of a summary into fetal growth restrictions. Now I open the floor to our moderators, panelists, Vivek sir, Radhamani madam, for their comments, adding questions, and to the attendees for their questions. So this is batch 2002. This was our first of the photos with Prem sir, Ron sir, and this was our convocation with Abdul Kalam sir and few of us there. Thank you so much, PG Nair ma'am and team, and Radhamni ma'am, for this opportunity that you gave me to come on the talk and give a few words from my side.
Thank you, Dr. ANU JOSEPH ma'am, for that insightful presentation. You have shared some thought-provoking points with us today. We are going ahead with panel discussion. I request Dr. Radhamani madam to start the discussion.
Hello, hi Anu.
Hello, ma'am.
So, as far as the clinician is concerned, small for gestation age, there is no need for early delivery because the outcome is not dependent on it. And coming to the prediction, we are in a long way because by starting the aspirin, we are able to reduce the incidence of severe fetal growth restriction. And then 3C, when as a clinician, I will see 3-4 things. When there is a growth restriction, first of all, I will ask about the movement, whether she is appreciating good movement. Number 2, I will see the amniotic fluid, whether it is less than 8 or within normal limits. Number 3, I look for the CP ratio. Is it more than 1 or less than 1? And then the umbilical artery flow. If it is umbilical artery flow, we know that at less than 32 weeks, we will wait for the ductus venous flow. But there are instances where combining all these things, we will not wait up to 32 weeks. Even though you people say that there is to be, we will depend on the ductus venous flow, that means there is right ventricular failure and that much of hypoxia to the fetus. If the neonatal care is excellent, we could terminate little early rather than waiting till your 32 weeks. And moreover, these patients have already some medical problems as well. So when the mother is stable only, in preeclampsia, severe preeclampsia, we had enough cases, lot number of cases. Last week also 2 cases I had. At 30 weeks and the patient is come with umbilical artery flow absent. And then after admission, the BP is 150, 100, and afterwards it rose to 170, 110 with a persistent headache. Because I got call at 7:30, 9:30, 10:30, 12:30, 2:30 and 3:30. I told, okay, you prepare for section, because I worried about a headache which can lead to press or which can lead to eclampsia. We can save the mother, but if it is cerebral hemorrhage, we can't. So depending upon the maternal factors also, we may need to change. We will not wait. We will not rely on your findings. We will see the mother and the fetus. These are the experiences that I would like to share.
Thank you. That is exactly what makes managing fetal growth restrictions very difficult, because there is also a maternal component that we'll have to look at.
I think we would like to hear from Vivek, an expert opinion. Vivek?
Yes, sir. Can you hear me? Yeah.
Yes, yes.
Yeah, Anu, first of all, fantastic talk. It's quite a difficult topic to speak to a general audience, and I've heard a lot of senior people mess it up completely, but you made it very, very simple, and you highlighted the importance of identifying growth restriction early, even to non-gynecologists and the non-fetal medicine specialists. I think that is the key, because this is one of the most known preventable causes of stillbirth. If you identify growth restriction in time, as she said, and you manage it appropriately, you can bring down the number of stillbirths or unexplained stillbirths by a large extent. So identifying is the key, and you rightly brought out all the points of how to identify what are the risk factors and so on and so forth. So very well made talk. Anu, congratulations.
Thank you, sir.
I don't think I have any questions for you at this point in time. If there's anything that the general audience would like to ask, I'm happy to take them as well.
I think
so one question has come in. I
Yes.
think you are the better person to answer this. In early onset fetal growth restriction detected after anomaly scan, is it okay to start? So they understood it's not recommended, but is it okay to start low dose aspirin if patient was not on it, especially if uterine RGPI is a bit high?
You want to take that?
No, sir.
Or should I? Okay. So yes, so the evidence is very clear. So the mechanism of action of low dose aspirin for this particular indication is that it modifies placentation. So it modifies trophoblastic formation and trophoblastic invasion. So if that has to take effect, it has to be given before 16 weeks, because we know for a fact that the placentation is complete by 16 weeks of gestation. So starting aspirin after 16 weeks may not have the same effects as starting it before 16 weeks. But having said that, there's a large consensus opinion that was published a couple of years back in the American Journal of Obstetrics, which said there could potentially still be a benefit of starting aspirin even up to 28 weeks of gestation. Even though it may not entirely modify the placentation per se, it could have some fringe benefits, and therefore it is recommended that even if you pick up after the anomaly scan, if there is an early onset growth restriction, empirically you're not wrong in giving low dose aspirin, even though that may not be very much evidence based. The evidence is very clear. You have the benefits only if you started before 16 weeks of gestation. But based on this one piece of information that you have, which is a consensus opinion published in the AGOG, and remember, consensus opinions are not considered very high in the hierarchy of evidence, but still, that's one document that you can fall back on to say that even if you pick up early onset growth restriction after the anomaly scan, you're probably not wrong. I would not say that you're entirely right, but you're probably not wrong in considering low dose aspirin, even in those subset of women.
Maybe we routinely when patients are trying for IVF, we routinely start low dose aspirin so that it is a precious pregnancy, because there will be some other factors like endometriosis, fibroids. So we don't take chance. We just take a low dose aspirin. Only thing that people usually are worried when we start aspirin empirically, they will tell that they are worried about the especially if there is some spotting or bleeding, they will attribute it to the low dose aspirin. So even today I had to tell the patient that it doesn't cause that much. Only if there is a big hematoma in the scan early trimester, we have to stop that. Otherwise, it is not advisable to stop just because it may be implantation bleeding. So we must not stop. So what is your opinion, Vivek and Anu, I think? Yeah.
So stopping ecospirin for implantation bleeding or first trimester bleeding is not recommended. There is, we have continued most of the time, and patients do well. Probably giving something to stop the bleeding, like a progesterone, excess of progesterone from what they were already taking, would stop the bleeding, and patient usually does well even on aspirin.
So the message must be that aspirin won't affect the normal menstruation. If the patient is previous history, we start periconceptually low dose aspirin.
Menorrhagia as a part of ecospirin, no sir, we don't.
Yes, that was the message I wanted to convey, that you can take it even during the periods. You can take the low dose aspirin. Dr.
In
Shobha.
late onset FGR, MCA-PI less than 5th centile is an indication for delivery. MCA-PI alone as a factor, no. It is considered as, unless you are starting to see other issues, like there is a non-progressive growth. There is also an umbilical artery Doppler, which is bad, and your CPR ratios have gone bad. You can also look at the further down, what all are there. You can look at the ductus venosus flow and PI and then decide. But otherwise, sir, what is your take on it? Just by an MCA-PI being less than 5th centile, should we deliver the baby?
Yeah, so I think we have to be clear about the difference between what is a diagnostic Doppler and what is a prognostic Doppler, and what are your delivery triggers. These are three entirely different concepts. Now, MCA-PI is mostly used for diagnosis, never used as a trigger for delivery. So that's what we need to understand. Your triggers for delivery in late onset FGR are any abnormality on the CTG, because that is telling you that the brainstem is hypoxic. A hypoxic brainstem is what is going to produce abnormalities on the CTG. So if you find a hypoxic brainstem, remember a mature brainstem is very sensitive to hypoxia. You can have a sudden intrauterine demise of the brainstem exceeds a certain threshold of hypoxia. So if you find a brainstem abnormality in terms of abnormal CTG, or you find that there are unprovoked late decelerations, these are all definite delivery triggers. Now, MCA-PI is not one of the delivery triggers. You use it mostly for diagnosis. If you have a baby that is below the 10th centile and your MCA-PI is abnormal, then you could probably call it as growth restriction. So that's a diagnostic Doppler, but you rely much more on the CPR, as Radhamani Madam said, rather than on the MCA-PI alone. Because we have to understand that CPR is one tool that becomes abnormal even before the MCA or the umbilical artery individually becomes abnormal. And if you look at the longitudinal fall in CPR compared to that of the longitudinal fall in MCA-PI, CPR is much more pronounced. So you always look at CPR these days, and we don't really bother on MCA-PI, even for diagnosis for that matter, because your CPR becomes abnormal even before the MCI becomes abnormal. So in short, MCA-PI is neither a diagnostic, it is a diagnostic tool, but we don't really find clinical use for it because you have a much more sensitive tool in CPR, and it's never a delivery trigger. The whole idea of delivering in FGR is to prevent severe acidosis or severe hypoxia, depending on the gestation age. If you've crossed a gestational age where lung maturity is reasonably assured, let's say 32 weeks, beyond 32 weeks, you would deliver if there's any signs of severe hypoxia. But if the baby is quite immature, 28 weeks, 29 weeks, then you would probably balance prematurity versus the risk of hypoxia. And if you think that prematurity is more of a detriment, you'd probably wait till there is severe acidosis. There are definite diagnostic criteria for each of these, and your triggers for delivery are any of those signs of severe acidosis, like a reversed A wave in the umbilical artery, reversed ductus venosus blood flow pattern, unprovoked late decelerations, so loss of short-term variability on the CTT. So these are all triggers for delivery. It's really not the MCA-PI that is a trigger.
Again, sir, the same question. Can CPR less than 1 alone be taken as an indication for CS? The Dopplers are never, unless really bad, showing reversal and things like that. CTG is your better choice at deciding on when to deliver. Correct, sir?
Yeah, so this again has become very objective. So once you follow one of the said protocols, like the Barcelona protocol, or maybe even the EastWalk protocol, there are very set guidelines as to what you do in which particular situation. So a CPR abnormality alone is not going to decide on the mode of delivery per se. For example, if it is a CPR abnormality alone and the baby's just growth restricted, late onset growth restriction, the CPR alone is abnormal, and she's crossed 37 weeks of gestation, you can very well try for a normal delivery or labor induction, but with probably a low threshold for cesarean section. So it's never a direct indication for cesarean, but if it's the same thing that happens, let's say at 34 or 35 weeks, and the baby has not reached term, then of course even a CPR abnormality with any of the other delivery triggers, your mode of delivery would be cesarean. So the mode of delivery is decided not just by CPR alone, but by a combination of factors, which includes gestational age, whether or not she's crossed 37 weeks, whether you have one of those major delivery triggers of severe acidosis. You would not want to subject a severely acidotic baby through the stress of normal delivery. In such cases, obviously, CS becomes a direct choice, but it's never based on the CPR alone.
We have a question from Jairam sir from Manipal. What is the role of sildenafil in IUGR?
Are you taking that, Anu?
No, sir. It's again controversial.
Okay. So sildenafil, if you go by current evidence, we had the Strider trial, which really looked at the roles of the role of sildenafil in growth restriction. So that trial had to be ended prematurely because there were a couple of more than a couple of deaths that happened, fetal and neonatal deaths. So the Strider trial was stopped prematurely because of that. And if you go by current evidence, the sildenafil is definitely not recommended as a primary mode of treatment or prevention in growth restriction.
At one time we were using, but it is not now.
Yes, because the risks outweigh the benefits. We were doing a trial on our own as well at AMRITA with Dr. Raju, but that again had to be stopped because the data was overwhelmingly against the use of sildenafil antenatally because of the risk of fetal demise or in utero fetal demise.
We can stop. Shobha, do you have any? Shobha, hello?
Yes, ma'am. No, it was an excellent presentation by Dr. Anu, and actually, Vivek has bombarded with lot of points to all of us. So the session was very good, excellent. I don't have much to say. Thank you.
So there's just one more question. Okay, two more questions. MGSO4 is useful till what gestation? To the best I know, 32 weeks. At 32 weeks and beyond, we don't generally give it. Neuroprotection, 32 weeks.
At one study shows you can even use up to 34 weeks.
It doesn't do harm, but neuroprotection, less than 32, no answer. Another question is from Dr. Chitra. When will you wait for DV to become abnormal to take a decision for delivery? This is an early onset growth restriction where you are running behind the prematurity, and you don't want to just stop at umbilical artery Doppler. You want to still give the baby a little more time. You may still wait for DV reversal, but again, of questionable benefit. Is that correct?
Because already the box is damaged. We will say too many things so that this is a long-term sequelae, and then why should we wait for that? If you have an excellent...
When we have an NICU, which is really good.
Definitely depending on the NICU, because long-term sequences are too many, and also awareness about that, then we are not able to go like that. And because when ductus venous abnormality occurs, umbilical pulsation, also you look at venous pulsation, then impending death. Definitely, usually we are able to see it. Normally it goes like that. Okay. Yeah.
Okay, I know that was an excellent presentation. I think, as Vivek told, it was very simply and excellent way explained rather complicated problem. They made so simple, and I think the audience. Okay, one more question has come.
Genetic something.
Yes. Can you answer that? Genetic abnormalities can occur in early fetal growth restriction. What are the indications for genetic testing in early FGR?
So FGR seen at anomaly scan itself is taken as a trigger for testing for genetic anomalies actually. Even if we don't find any other added markers. If we find another added marker, say for example, an absent nasal bone, it becomes an additional marker for us to be quite confident in asking them for doing it. But otherwise, early growth restriction less than 20 weeks itself can.
Bad obstetric history, repeatedly growth restriction and all, actually autopsy will tell you what is the, so Sheila is having so many syndromes.
So just a simple early growth restriction itself may be an indicator for testing for genetic anomalies.
One more question is there. Can you?
Yes, the answer is given 37 weeks. So as long as it's only AC and EFW which is there. So the best thing is to look through the graph that Professor Gratikos and team has given. They have very nicely, if you just want to have okay, this scenario, what to deliver, this is that paper is very good. AC at 5th centile, EFW at 6th centile, it tells us that yes, this baby is growth restriction, but the Doppler is normal. So we don't need really to deliver them. You reach 37 weeks. Yes, growth restrict baby at 37 weeks, induce, deliver.
So many other factors also when induction actually when you do, that again depend upon the Bishop score and also early ARM is
Yes. So that is why, ma'am, I said if it is just to understand this stage what to do, that paper is good. But maternal considerations are always there, and it makes the decision very varied.
Thank you, panelists, for your thoughtful discussion. And thank you, Dr. ANU JOSEPH, ma'am, for your responses. This has been a great discussion. Now, I call upon Anjali EA, Executive, Alumni Office and Nodal Office, AIMS Kochi, to deliver the vote of thanks. Anjali, please.
Thank you, Abhirami. Namashivaya. A very good evening, one and all. It is my privilege to extend a heartfelt vote of thanks on behalf of AMRITA campus alumni. First and foremost, I would like to thank Amma, the Chancellor of the University, for all her blessings and being our guiding light in all our endeavors. I express our deep sense of appreciation and gratitude to Dr. Prem Nair Sir, Group Medical Director and Provost, AMRITA Hospitals, India. Thank you, sir, for your gracing the function with your presence. Next, I would like to thank Dr. Girish Kumar KP Sir, Principal, AMRITA School of Medicine, AIMS, Kochi. Thank you, sir, for your kind support in all the alumni activities. I am honored to extend my gratitude to Dr. Radhamani K. Ma'am, Emeritus Professor, Department of OMBG, AIMS, Kochi. Thank you, ma'am, for your constant support and engagement in all the alumni activities. Next, I would like to thank Dr. Fessy Louis Sir, Professor and Head, AMRITA Fertility Center. Thank you, sir, for your support and encouragement. Next, I would like to thank Dr. Shobha S. Nair Ma'am, Professor and Head, Department of OBG, AIMS, Kochi. Thank you, ma'am, for your contributions. Next, I would like to thank Dr. Vivek Krishna Sir, in charge, Fetal Medicine Unit, AIMS, Kochi. Thank you, sir, for giving your valuable time. Next, I would like to extend my heartfelt thanks to Dr. P.G. Nair Ma'am, Emeritus Professor, Pharmacology, Coordinator of Nodal Office for Statutory Inspections, and Chief Coordinator for Campus Alumni, AIMS, Kochi. She is always there with suggestion and encouragement and boosts one's morale with her positive words. She is the strength and backbone of all the alumni activities of the campus. Without her support, all these programs would not have happened. Thank you, ma'am, for being the core strength of our campus alumni. Next, I would like to express our sincere gratitude to Dr. ANU JOSEPH ma'am, Senior Consultant, OBG, Kauvery Hospital, Bengaluru. Thank you, ma'am, for delivering such an insightful and inspiring talk. Your knowledge and expertise have not only enlightened us, but have also given us valuable perspective to take forward and was useful for all the PGs. We will be posting it on the YouTube for the benefit of all those who missed this CME. I would also thank the host of the program, Ms. Abhirami Jayakumar, Executive, Alumni Office and Nodal Office, AIMS, Kochi, for the excellent hosting of this program. And I'm really grateful to Smita Chichi, the core member of Alumni Office, for her support throughout this program. I would also like to thank all the professors, faculties, students and delegates who attended this CME, and also thank audio video team, IT staff for all the hard work and dedication which made this event possible. Once again, a big thank you to Dr. ANU JOSEPH, ma'am, for your time and for sharing your wisdom with us. We deeply appreciate it and look forward to more opportunity like this in the future. And I request Dr. PG ma'am to give the certificate of appreciation to Dr. ANU JOSEPH ma'am.
Namashivaya and Anu, I'm sure you're very happy to be back here. I request Dr. Radhamani madam to come because both of us are your teachers. So we are.
Actually, Radhamani madam is not my teacher from AIMS, but she is my teacher. Yes, she is my PG teacher from Kauvery.
Under her, yeah. So I am usual teacher and she is PG teacher.
Yes, and I'm very happy about this.
Yeah. So both the teachers are giving you this certificate. It will come to you online.
Thank you so much, ma'am. I deeply appreciate this. Thank you so much.
And all the best to you.
Thank you.
Thank you, Anjali. We end our CME today with the national anthem played in violin by Dr. Siddharth Vishwanath, who is an alumni of 2002 MBBS batch of AIMS and is presently a vascular surgeon in our hospital. Thank you all for being a part of this important event. Your presence and participation truly enrich our discussion and knowledge. Thank you all. Goodbye to all of you till we meet again.